Thank you for joining us for the Kirby Institute seminar series. My name is Alison Marshall. I am currently a lecturer as part of the Kirby Institute and the Center for Social Research and Health. I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today and pay my respects to elders past and present. Today we are presenting from Bidjigal people of the Eora Nation. I extend that respect to Aboriginal and Torres Strait Islander peoples joining us here today in the audience and online. Some quick housekeeping to start off with. The format for the seminar will start off with a presentation followed by a Q&A session after. If you are joining us online today, you can ask questions throughout by clicking on the Q&A icon at the bottom of the screen. For our audience in the room today, of which it's nice to see plenty of you here, a microphone is available to the side of the room to address your question at the start of the Q&A session at the end of the presentation. But now I'd like to start off by introducing our speaker today. This is Anna Conway, who has addressed herself as a research associate, I noticed. Yes, no, so Anna is recently submitted her PhD. So she's a PhD candidate and also a research associate as part of the Viral Hepatitis Clinical Research Program, and also her work at the Center for Social Research and Health. Her research interests include drug use, drug treatment, and hepatitis C. Anna's research draws on epidemiology and social sciences to explore barriers to health and well-being at the program and policy levels. This is a very short bio on the part of Anna, but I will also say that she has a gazillion publications. I lost count when I was going through the PubMed search, of which she is the lead author of at least 5 of them as part of her PhD. She also went and did a nice internship at New York University, which is lovely, and which she got a first author publication out of that. She's also been involved in a lot of ethos campaign days. She's been teaching courses. She's been doing ethics applications. So Anna does a lot. And so we're very excited to have her present today. And it's been a pleasure having you as a student. So I'll let you get going.
Today I'll be presenting my PhD thesis, Developing Enabling Environments to Improve the Health and Wellbeing of People Who Use Opioids. Most of this work took place on the lands of the Bidjigal people, and I want to acknowledge that sovereignty was never ceded and pay my respects to elders both past and present. The thesis is in memory of Jude Byrne, who was a powerful advocate for the rights of people who use drugs. She was really involved in the design and the recruitment for the choice study, which I'll talk about later. And first, I want to thank a fantastic supervisory team on the PhD, Alison Marshall, Carla Trelaw, and Jason Grabley. I want to thank everyone that gathered time to take part in this study, and the Choice Community Reference Panel that was convened by Jude Byrne. And the PhD was funded by a UNSW Scientia scholarship. So firstly, start with a bit of background. A lot of research on people who use drugs is grounded in the deficit approach, and that really focuses on positioning all drug use as problematic and posing people as incapable or uninterested in protecting their own health. And that results in paternalistic approaches to care. A body of literature and critical drug scholarship challenges that view, firstly, from an ethical standpoint, that it's wrong to treat people as less than just because of their drug use, but also from a practical standpoint, that only gives us a very narrow view of what's actually happening with people's health. So taking that deficit approach really creates that reinforcing narrative of individual deficit within the health system and for health provider behaviours, resulting in care that's often inadequate for people who use drugs, or resulting in stigmatizing behaviours when people try to access healthcare. So most of this research that I'm presenting today focuses on people who are engaged in opioid agonist treatment. In Australia, that means methadone or formulations of buprenorphine. In 2022, there was an estimated 55,000 people receiving opioid agonist treatment at 3,000 dosing points across the country. Dosing points, depending on the state, are either public clinics and or community pharmacies. And often people are required to attend for daily supervised dosing, which is integrated either at the public clinic or community pharmacy. like I was saying before about the issues with that deficit approach that's embedded in a lot of research, what are the impacts whenever we think about the health services? And so this quote from Substance and Substitutions that was published 15 years ago is still pertinent today. Clients are constituted in treatment as they are in public discourses as unreliable and deficient, and this is materialized in regulatory practices through risk management. So what we see is that within the OAT programs, people who are being constituted as less than or deficient often results in a paternalistic mode of provision of opioid agonist treatment. So to look beyond that deficit approach and think beyond just the individual behavioral factors that influence health, I use the social ecological model for health to frame the thesis findings. So I'll start with the individual level, thinking more about factors associated with overdose and naloxone access, but that's embedded within network, community, and policy factors. This work that I'm going to talk about now is published in the International Journal of Drug Policy. And it draws on ethos and gauge, which you probably have seen presented here before. So this work draws on wave one. Ethos and gauge was or is an observational cohort study monitoring hepatitis C. But as part of that, people complete participant surveys about a range of topics. So for wave one, it was recruited between May 2018 and September 2019. And for this analysis, I'm looking specifically at people who recently used opioids or received opioid agonist treatment. That's about 1,200 participants. And the aim was to identify factors associated with recent non-fatal opioid overdose or lifetime naloxone access. And naloxone is a medication that can be used to reverse overdoses, opioid overdoses, and can be distributed and administered with very little training, making it appropriate for lay people to use. So in that sample overall, there were 7% of people who reported non-fatal opioid overdose in the 6 months prior to recruitment. Non-fatal opioid overdose was associated with using multiple depressant drugs in the 6 months prior to recruitment. Engagement with opioid agonist treatment for more than 2 years was a protective factor in a recent opioid overdose. Then thinking about lifetime naloxone access, overall, 17% of people reported ever having access to naloxone. Again, this was associated with people who had used multiple depressant drugs in the 6 months prior to recruitment, which is promising that those people are at higher risk of overdose or also are more likely to access naloxone. And then being engaged with opioid agonist treatment for more than 3 months was associated with increased access to naloxone. From other literature, we know that non-fatal opioid overdose is a strong predictor of future overdose. In this sample, the 91 people who had reported recent opioid overdose, 2/3 of them had never accessed naloxone. So this data is from 2019, and since then there's been a lot of changes with the rollout of the National Naloxone Program, which has increased access, but there's still large gaps in naloxone access and a need for novel distribution strategies. So the next 3 analyses I'll present are from the CHOICE study. So I'll give it a bit of an overview about them first. Opioid agonist treatment provision in Australia had long been criticised for being burdensome and restrictive. I mentioned earlier a lot of programs, a lot of dosing regimes rely on supervised daily dosing. So in 2020, with the start of COVID, there were concerns about people who were being asked to attend for daily supervised dosing, and additional concerns because not only were people being asked to have high contact with health services, but also people receiving OIT tend to have more comorbidities and more socioeconomic vulnerabilities. So there were guidelines brought out at the state and national levels, which largely recommended reducing supervised dosing and reducing in-person appointments and reducing biological monitoring such as urine drug screening. So the design of the study was to conduct interviews with 70 people at the end of 2020. 40 of those people were receiving OIT. They'd been receiving OIT on average 10 years, and the majority of them had injected drugs since the beginning of the pandemic. Then I also conducted 30 interviews with people providing OIT, a mix of nurses, doctors, and service managers. The majority of those people were working in public clinics. So the first analysis, we think about health protection strategies that were employed outside of the service to begin with. And this is published in Drug and Alcohol Review. The aim of this analysis was to understand how people receiving OAT experienced COVID and restrictions, and how people responded to that to mitigate negative health outcomes. And for this analysis, I considered people receiving opioid agonist treatment as a counter-public. So when all those, when the COVID guidelines and restrictions were introduced, these people were largely not addressed in mainstream public health response, and so were perhaps, for that reason, they had to implement their own strategies to protect their health. And the first finding from that analysis thinks about the COVID restrictions for an idealized public. So in the example of Tom, we saw how the introduction of some of the recommendations and guidelines, like using the COVID tracker app, wasn't appropriate for everybody that it was being recommended for. Firstly, those responses to big events such as COVID-19 risk causing harm when imagined for an idealized public. So a lot of people had distrust already in the health system, distrust in the state. They weren't going to, or a lot of people were reticent to use some kind of tracker app that was implemented by the state. But especially in the case of people like Tom who were using drugs, they were wary that the tracking app could be possibly used when he was out scoring. That was exacerbated by the restrictions through enforcement and policing rather than cooperation. Tom, when he was trying to follow harm reduction recommendations to use drugs with other people and not use alone, he felt that that wasn't compatible with using the COVID tracker app. And we also saw other examples of counter-public health practices. In some cases, those harm reduction strategies were colliding with strategies to reduce the risk of COVID transmission. And what was common to a lot of the interviews was that COVID was just one of a number of competing priorities and often was not the priority for people, even at any stage of the epidemic. So this example from Leah. Leah had gone to buy at a drug seller's house, and then instead of using it within his house, had taken out to her car. And then after using in her car, fell asleep and woke up with a burn from falling asleep on a heater in her car. And she said she usually uses it at home, but sometimes uses it at the place if she's not sure of the gear. So employing those health practices to make sure that she was safe when using new drugs. And I asked what made her use it in the car that day, and she said she didn't want to hang around at the dealer's house because of COVID. So moving on to the next analysis, now we're thinking about the provision of opioid agonist treatment and how that impacted people's broader health outcomes. This has been published in the International Journal of Drug Policy. So first, that emergent adaptation that I described in the clinics, which constituted mostly reducing supervised dosing, reducing in-person appointments, reducing urine drug screening, with a view to reducing foot traffic around and reducing COVID-19 transmission. But the outcomes of all of those changes to services, which weren't done consistently across clinics, but most clinics introduced some level of change. The outcome of that was impacted people's wider risk environments and may have produced enabling environments for people who use opioids. So the aim of this analysis was to understand how adaptations in the complex system of OAT provision impacted and responded to the risk environments of people receiving opioid agonist treatment during the pandemic. And for this, I'm using a theoretical lens of the risk environments, thinking about the different environments that could influence the outcomes. Here we focused on 3 outcomes: COVID transmission, unintended effects of unsupervised dosing, and OAT non-adherence, and consider them from the physical, economic, social, and policy factors. So first, thinking about how COVID-19 influenced those risk environments, there were a lot of adaptations to the provision of OAT itself, but also those adaptations that were seen across lots of different health services. So aspects of provision that before may have implied person-centered care were deprioritized in order to serve the needs of a more general public. So this was Annabelle's experience talking about going to her dosing point, going to a clinic. So people were queuing outside of the clinic, and there was, when they were in the queue, then they were told to follow social distancing guidelines to reduce the risk of COVID. Once inside the clinic, she felt the clinic workers didn't care about them. It came from a place of don't make me look bad. You guys need to keep separate, because rather than you guys need to keep separate because COVID was going around. So outside of the clinic, the kind of visual of the dosing point was more important to the clinic workers than actually reducing the risk of COVID for people who were engaged in treatment. A big concern with all the increased flexibilities that were introduced in opioid agonist treatment at the beginning of the pandemic were, from the provider's view, the risk of associated adverse events that might result from increasing access to unsupervised opioid agonist treatment. So that came a lot from the provider side, but from people who were actually experiencing the changes, they reported a lot of beneficial aspects. So firstly, flexible opioid agonist treatment provision meant that people, because they didn't have to attend so often for supervised dosing, they were less likely to be considered non-adherent if they perhaps took a dose at a different time during the day, or it left it up to them to be able to manage their dosing themselves. So in Sam's example, Sam describes how he's not a morning person, so getting those takeaways was much more convenient, much less stress, and he was more physically stable because he wasn't missing doses. He also found it empowering and took a sense that the clinician felt that they could trust him to have 6 takeaways. He says it felt like a normal person. And then the next analysis from the choice study, we think more about the work of the providers in implementing these changes within the clinic. It's been published in Implementation Science. So this part of the analysis thinks about de-implementation as the removal or reduction of potentially hazardous approaches to care, which is what can be described as the reduced supervised dosing and urine drug screenings within the clinic during COVID. And those kind of removal of hazardous approaches to care are key to achieving social equity and health. So the aim is to explore how providers consider social inequity in relation to the implementation of that restrictive OAT provision during COVID. And I won't go too much into it here, but I used the theoretical lens of normalization process theory. And here I'm just focusing on adaptive execution. So it's the idea that the clinician could implement or de-implement these processes, but also make the adaptation, the choice to adapt those implementations to make it suitable for people who are receiving treatment, and also make it more suitable for the person that's providing the treatment. The experience of Provider 20 highlights those tensions between the provider's conceptions of equity and patient autonomy. So while adaptive execution has that potential to really challenge social inequities in health, in the case of Provider 20, they utilize those processes of de-implementation for other patients to rule out some paternalistic control of other health issues. In this case, it was seen whenever I asked Provider 20 who might not be suitable for those flexible provisions of OAT, they replied maybe somebody that's having hepatitis treatment. They could be asked to continue attending for supervised dosing, because that would allow us to monitor their engagement with DAAs. And we also saw some similar findings for people with mental health issues. If they're not coming in for supervised dosing, how will we monitor them for mental health issues? There were also tensions between equity and unequal care. So introducing those flexibilities gave some of the providers a bigger degree of autonomy when providing treatment. But this was uncomfortable for provider 14, who said, I sometimes wish the rules were a bit more black and white, because you do find after looking after 60 clients, one person will say, well, how come Dave got this? And you're like, well, because of the situation. And they're like, that doesn't feel a bit fair. So there were those tensions arising between trying to give trying to provide equitable care, but the people who attend the clinic, who speak to each other, they understand that it's not going to be equal, and they want justification for why that is, which could impact the patient-provider relationship. And then finally, for public policy, we'll go to the US, where I looked at laws which restrict access to methadone. This has been published in IWP. So firstly, a bit of background in the US context that's a bit different from Australia. Largely access to OIT is lower, but it's also more restrictive in a number of ways. So like I mentioned here, dosing points are a mixture of community pharmacy and public clinics, whereas in the US, methadone is only available in opioid treatment programs. So you can't have a methadone dose at a community pharmacy. Opioid treatment programs are governed by federal guidelines. They require supervised dosing to some extent, and also require urine drug screening. The language that they use in the federal guidelines and a lot of the state guidelines is maybe more stigmatizing than we would see in Australia. They suggest urine drug screenings to be done with an unpredictable routine, so more of an idea of, rather than clinical monitoring, an idea of catching a person using drugs. And also recommends that they talk about urine drug screening as drug abuse tests. So already federal guidelines are fairly restrictive. This study aims to define a typology of states according to restrictiveness of opioid treatment program regulations at the state level. So thinking about what laws have been implemented on top of federal legislation, and to examine population characteristics associated with class membership. To do that, a latent class analysis of the regulations was followed by a class-weighted multinomial logistic regression to assess correlates of that class membership. So one of the collaborators in this study, Pew Charitable Trust, developed a legal database of 24 state-level laws. We selected 11 of those laws which were restrictive, and I won't describe them all, but just some examples. So the first ones focus around access to services, so what might prevent or support, what might prevent an opioid treatment program from opening and from operating. So that's things like additional bureaucratic requirements, like requiring pharmacy licenses for all OTPs. And also included things like zoning restrictions, so prohibiting OTPs from opening within X meters of a school, for example. Then there were the laws that restrict the patient experience, so requiring that urine sample screenings be observed, or requiring that take-homes were prohibited in the first 30 days. So using the latent class analysis, we categorized the states into three classes. The light purple are the states that didn't enact laws in addition to the federal laws, or very minimal laws that restrict access to methadone. And then the middle purple was medium restrictiveness on patient experience, high restrictiveness on access to services. And dark purple was high restrictiveness on patient experience and low restrictiveness on access to services. So using the class with very low restrictiveness in addition to the federal laws, as the reference class 3, the factors that were associated with being in class 1 at the state level were higher unemployment, not including methadone and Medicaid coverage, higher opioid dispensing, and higher HIV diagnosis attributable to injection. And then the same again, using class 3 as the reference group, the factors associated with being in the more restrictive class 2 were having higher proportion of Black population, having higher proportion of people who are uninsured, having lower urbanicity within the state, and higher opioid dispensing. So how do we draw all these findings together, and what does that mean for creating or informing those enabling environments to improve the health of people who use drugs? So we see that in a lot of ways, healthcare settings can be hostile places for people who use drugs. And that's the healthcare settings that are for the general population, as well as directly for people who use opioids or engage in treatment. We saw how the practices of care employed outside traditional healthcare settings are integral to the health and well-being of people who use drugs. There's potential for better distribution of naloxone and training. We saw the importance of those counter public health practices, especially during a big event such as the COVID-19 pandemic. And it's important to make sure that those health protection practices are supported and resilient for other big events going forward. Within the opioid agonist treatment provision, we saw there's an important role of choice in the provision of that treatment, and especially taking into account the people have different treatment goals and how those how people can be supported through through a flexible dosing schedule, for example, to live a life that they described as more normalized. And also there were rapid changes to the treatment provision during COVID. There was a lot of experience, evidence, momentum built up during that period, but already some of the states have rolled back the flexibilities that they introduced during COVID. It also showed the potential for improving the patient-provider relationship to create positive enabling environments with the provider, which could lead to facilitating those co-created treatment plans to serve the treatment goals of the person engaged in treatment. Especially in the de-implementation analysis, we thought more about centering equity and service change. So often changes to health services are very complex. It can be very difficult to isolate singular interventions from their to a singular effect. So any evaluation of these changes should take into account a very broad range of outcomes. There's also a key role of the provider in influencing those equitable health outcomes that's often overlooked when we're looking at individual level engagement with services. We also saw that some providers are more at ease than others when operating in that kind of evidence enough zone. So people, especially providers who didn't feel comfortable operating in that kind of grey area during COVID, when the regulations and the environment were changing very quickly. And then finally, analysis that look at the role of law in implementation are important, but there's a lack of good quality analyzable data to understand that. So in the study that I presented, I just looked at the laws as written, which has a number of limitations. There's a lot of variance in the interpretation of law and how the law is practiced. And especially within health services, how that is actually implemented has huge variation. And that should all be taken into account when interpreting the results. So thank you very much. That's everything. I'll take questions.
Perfect timing.
Yeah.
Perfect timing. I just wanted to open up the floor to questions. Okay, I'll get started. I wanted to get your sense of the evidence needed from practitioners to feel more comfortable loosening restrictions around the implementation of OAT in Australia. So what is it that people are primarily concerned with, and why they're not loosening there, or essentially also, there's flexibilities that were provided during COVID. Why do you feel like the states are going back to pre-COVID times?
Yeah, so when you look at the individual provider views, there's a real range, and it's somewhat tied to the provider's experience, I think. So in some cases where providers have decades of experience and they're quite comfortable with those flexibilities, and they kind of have confidence that they're able to decide on a person-by-person basis, versus those providers that we see that are want very strict, these are the number of days you can have takeaways, this is the dosing schedule that should be implemented. So there's a bit of differentiation in the providers. So why, and what are the evidence that they're pointing to? In the interviews, it was often around the providers who said, why are we doing this? We need to wait to gather more information, more evidence. We're usually pointing to adverse events, which they discuss this, diversion, increased overdose due to methadone and buprenorphine. What's interesting is, what I think is interesting is, at what level would there be acceptable evidence generated? So they had the information from their clinic level.
Yeah.
All the providers are confident that they know if there's an overdose within their patient, like among their patients. So it made me question, are they looking for state level, national level? How would we ever have that evidence? Because the clinics were implementing at such a with such variance, it would be very difficult to kind of, again, isolate that cause and effect. So I think all of that and making kind of a general lack of consensus is probably the reason why states are rolling back to the pre-COVID recommendations. And I think just a general kind of risk aversion that they, at the state level, they're concerned about being seen to support a policy which perhaps could result in increased overdoses when there's kind of a large awareness of drug related deaths maybe in the media at the minute. But I do find that because Australia is kind of out of step with other comparable countries like Canada, UK, that I thought perhaps that momentum and the knowledge that was generated from COVID would be more pushing the state guidelines further forward to be more aligned with
right.
UK.
And to your knowledge, has there been evidence collected about these, like whether or not there actually has been more adverse events during COVID or following COVID?
Yeah, so I think there's been studies in Southeast Sydney and like more at local level, which didn't find it associated with more adverse events.
Amazing talk, Anna. Can you share any insights you might have on recent changes to PBS listing of OAT and provision through pharmacy in terms of payments to pharmacies and how this might impact people on OAT?
Yeah, so I didn't flag it in this presentation, but it's a great question because it's very recent changes. One of the things that came up in a lot of the interviews with people with economic instability and how that was, especially during COVID, and there was a lot of economic insecurity that was exacerbated by the pandemic. So the amount of people's incomes that they were spending on their opioid agonist treatment was like a fairly big proportion at some points for some people. There's also the tie between and providers would talk about this as well, that in order to, if you have someone who isn't able to pay, they oftentimes have to attend a public clinic to get free access to treatment. And that has implications for how much you have to go for supervised dosing, how able you are to engage in care work or in paid work. So that was all kind of wrapped up together with the costs, the out-of-pocket costs of opioid agonist treatment. So the changes to the listing in PBS were really what a number of people, including providers, were calling for, making it more accessible to people who want to be engaged in treatment, making sure the cost isn't a barrier. I'm less across, I know there's been some issues with the implementation, but I'm less across what that is. But I suppose there is that issue of making sure that people are still able to access treatment and that the providers aren't, I don't know if there's maybe less economic benefit to some providers that might make them reticent to now supply OIT. So I think there might be issues with that implementation.
Sorry, Beza, do you have a question?
Thank you very much, Anna. Great presentation. Just in your interviews about OIT and COVID restrictions, I was just curious, did you have any sense of a kind of willingness towards shifting to actually the long-acting group during that period, either from the clients or from the providers?
Yeah, so that was something that we thought would come out a lot more in those interviews. And I think maybe because of the time that those took place, so we're talking in 2020, where it was being looked to as a great option to avoid clinic attendance. So the long-acting buprenorphine would either be administered weekly or monthly, allowing people only to attend weekly or monthly. And there was a bit of maybe there were some issues with some clinics actually not wanting that because it required more intense clinician contact during COVID. So I think some clinics were still reticent to roll it out. Since then, there's been like a huge uptick in the number of people who are receiving buprenorphine. And a lot of that I didn't interview anybody in prisons in the study, but a lot of that uptick in long-acting buprenorphine is due to the initiations in prison. And that, I think, was a real selling point for prisons during COVID, that they were able to retain people on treatment, but reduce the number of contacts that they had with people. So yeah, it looks like that's increasing as time goes on.
Yeah, I'm slightly surprised that there aren't better population level indicators of whether this was a good thing to do or not. I mean, this relaxing of I thought that there was more systematic collection of information. But do you think there's an element of the providers wanting to, is there a financial element of the providers wanting to maintain the more they get better funding or greater funding from the model that is more intensive contact? Is there any element of that in this retaining the system?
Yeah, so I suppose, I mean, I haven't gone into it in great detail, but there's different models in terms of the people going public or private. In theory, the changes shouldn't impact the income of pharmacists who are providing opioid agonist treatment. But I've heard that private clinics have closed because they're unable to, they say that whatever the cost margins don't make sense to them anymore. Whether that's, I'm sure there's people in the room that know more about it than I do, but yeah, whether that's like motivated by just the cost, or whether that was a model of treatment that wasn't viable in long term, I don't know. And yeah, in terms of there being like national analysis of the increased drug-related deaths, I suppose it's just that like variance between clinics and how it was implemented. So the guidelines were just guidelines, it doesn't mean that all clinics change their practice. So being able to understand what the population level outcomes were whenever clinics were doing such a wide range of things and providing OIT is maybe a factor.
I have another question for you. Maybe the last one. This is a bit of a lofty question, but I'm curious. We have another question as well. Because you spent some time in the US and we're able to look at their policies around the implementation of methadone and their delivery of methadone, was there anything that sort of surprised you about their approach in relation to delivery of methadone in comparison to Australia, or in terms of the type of restrictions that were placed? Like, what was your sense of what was going on? Like, what was the purpose of some of those, you think, in terms of being enacted? Or
yeah, so I think just really bound up in what I was talking about at the beginning with that deficit approach. It's a very more so than here, it's very politicized. There's one state that just doesn't have methadone access. It doesn't have any opioid treatment programs. And yeah, just shocking that people would have to attend these programs. To people that are keen to access methadone would have to attend these programs. But also that's what I was kind of alluding to at the end about when we do these analysis of laws, you know, it's fine to say these are the laws in that state, but if the state only has one opioid treatment program in the whole place, then you obviously have these barriers to access that are not clear from just looking at written laws. So that was shocking as well. But yeah, definitely that real hard line they've drawn between buprenorphine and methadone.
Right, another question.
Yeah, great presentation. I had a question about, so the increased flexibility seemed to be really helpful for the people receiving the treatment. And then you said that there were some providers that either thought it was a really good thing, but others said were reticent to have the flexibility because of that gray area. And you had that one quote where one of the providers said someone else in their clinic noticed that they were being treated unfairly. Did you notice that at all in the participant side? Did any first-hand accounts of them noticing this flexibility was giving people who were receiving treatment unfair, treatment, I guess?
Yeah, so I suppose key thing is you have people who have their networks, people who have other friends who are engaged in treatment, but you also have the public clinic as the actual space where people are attending every day. You see the same people in the wait room every day. Obviously, there's an exchange of information there. So I think most in the recruitment for this, and a lot of people were dosing at pharmacy and not at the public clinics. There was one person who reported something similar, I know my friend was getting this. And so in her case, she was able to use it as leverage to then negotiate for more flexible dosing. But I think it probably didn't come out so often because maybe of that pharmacy and clinic side. But yeah, it was coming out with the participant or the people receiving OIT as well.
Any final questions? Any final questions online? We're all good. Can we please give Anna a big round of